Bismillah ar-Rahman ar-Rahim. Minimal invasive fixation of pelvic fracture case presentation. As we know, the pelvis is the ring which transfers the body weight from the lower limb to the axial skeleton. And the pelvic fractures are usually the result of high energy trauma, and in most cases it is associated with other injuries, and the patient is a polytrauma patient. To remind you rapidly with classification of fracture pelvis. Fracture pelvis is either classified according to the mode of trauma or according to the stability. As regards the mode of trauma, Young and Bagres classification is used for classification of such type of injury, and it is either lateral compression injuries, which is subclassified into type 1 with posterior transsacral injury as regards the posterior ring, and bony anterior ring disruption, superior and inferior pelvic ramus injury. Type 2 transiliac fracture with anterior ipsilateral anterior disruption, and type 3 with ipsilateral and contralateral disruption. Anteroposterior compression type, which is either type 1, which is with minimally displacement anterior disruptions, symphysial disruption less than 2.5 centimeter, or type 2 with open book type, and type 3 with anterior and partial posterior disruption. The most severest form is the vertical shear injury with complete disruption of the hemipelvis with complete loss of the stabilizing factor, which is either anterior and posterior. As regard, in addition to the underlying disruption of the pelvic ring, bony pelvic ring, there is extensive damage to the surrounding soft tissue envelope, and so minimal invasive internal fixation of the pelvic fractures is recommended and is increasing in popularity with multiple new techniques. I will present the cases with minimal and invasive fixation. This is a case with female patient, 60 years old, with bilateral fracture pelvis. One side type C and the other type B, with anterior bony disruption through the anterior and inferior pelvic ramus. The classic management in this case is bilateral sacroiliac screw, and for the management of the posterior ring disruption, and external fixator for the management of the anterior pelvic ring disruption. The other case is transiliac posterior ring disruption through the iliac bone, and anterior bony disruption through the anterior and inferior pelvic ramus. In such a case, retrograde lateral compression, 2 retrograde lateral compression screw to stabilize the posterior ring, and external fixation to stabilize the anterior ring is enough. In these cases, it is D type 2 posterior ring disruption and anterior bony disruption. Also, antegrade lateral compression screw is reduction, and antegrade lateral compression screw is enough for such case. With this simple reduction and fixation in such cases, our policy is to remove the external fixator at 1 month and to delay the weight bearing for 1.5 months for the patient. As regards the posterior ring fixation, we saw that the 7.3 millimeter screw, either for the sacroiliac fracture or the sacral fracture, or for the lateral compression fracture, 1 screw is enough. 2 screw may be used in the lateral compression type, and it is more than enough for the posterior ring fixation. As regards the anterior fixation, the external fixation is not enough in high injury trauma or high injury impact trauma with comminution of the anterior and superior and inferior pelvic ramus. Also, the external fixator has many disadvantages: bone tract infection, loosening, maceration of the skin, loosening of the bone, and the compliance of the patient. So sooner or later, this fixation device will be removed after 1 month, or some surgeon extend it to 2 months. And the pelvic bone fracture, like other bone fracture, it may need more time to heal, more than 2 months. Even if you lift it more than 2 months, loosening of the bone will lead to loss of its function as a fixation. In such a case, it is bilateral fracture pelvis type C, with severe disruption of the anterior bony ring, we did bilateral sacroiliac screw and external fixation. We removed the external fixator at 2 months. Fusion occurred posteriorly, and the posterior ring is good. But unfortunately, the anterior ring passed to non-union, and the patient suffered from chronic bilateral inguinal pain. Since that time, we abandoned the use of external fixation as a fixation method for anterior bony pelvic ring disruption in severe comminuted cases. Only we just use it in simple cases. And we started to use the long segment fixation, as in such case, there is bilateral pelvis type C posterior sacral transsacral disruption, and the anterior there is bilateral bony disruption through the superior and inferior pubic ramus. We use the posterior fixation by the sacroiliac screw and anterior fixation with long segment fixation through stop approach with 8 centimeter incision, suprapubic incision. It allows long time of fixation, adequate healing of the fracture, and this is 3 years of follow-up. If you, this is after 3 years, the healing is adequate. There is impaction of some screw. This is due to the nature of the symphysis pubis, which is a little bit mobile joint, fibrocartilaginous mobile joint, and rigid fixation is not suitable for it. So every now and then maybe screw impaction or breakage occur, but with no revision rate. Another case, it is very high injury trauma associated with fracture neck femur, bilateral superior inferior pubic ramus. In such case, we did also long segment fixation. This is 3-year post-operative. Healing is adequate, but the main drawbacks of such surgery, it is lengthy in time, increased blood loss, associated with other comorbidities for the patient, injury of important structure. If you recognize this, one of the comorbidities, if you recognize X-ray, this X-ray is 3 months post-operative. And we, in 6 months post-operative, we recognize this towel. I missed this towel inside the patient. And after 6 months, I brought the patient and I told her that we need to remove some screws. And we removed such 2 screws and removed the towel. This is one of the drawbacks of this extensive surgery. So we started to use the pelvis bridging technique for such anterior injury. In such cases, there is a comminution of the superior and inferior pubic ramus extended to the iliopectineal eminence. We used the infix technique. Posteriorly, as usual, the sacroiliac screw. Anteriorly, the infix technique is used until the sciatic buttress with good purchase, feasible and easy, minimally invasive, no loosening, no infection or brain tract infection. You can leave it as much as you want. This is a 9 months follow-up, and it was removed after 10 months. Also, anterior symphysial disruption can be managed minimally invasively. It is a case of the fractured pelvis type B with the anterior symphysial disruption. As usual, posteriorly, the single 7.3 millimeter sacroiliac screw is used. Anteriorly, we started initially to use a single 7.3 millimeter screw. And we started with single screw, and then this is a fractured pelvis type C, closed reduction with closed method and internal fixation for the symphysial diastasis. And this is 1 year follow-up with a reaction, very good reaction. The patient returned with his life, no comorbidities of open technique for plating, no problem of breakage of the plate or backing out of the screw, which mostly happen in this rigid fixation device with the mobile or little mobile symphysis pubis. This is the elite view And this is the outlet view. Another case, it is posterior ring disruption transiliac, lateral compression screw posteriorly, single screw, and two 7.3 millimeter screw anteriorly. Last case, another case, a home message. It is minimal invasive technique for pelvic fracture is increasing in popularity, and it is beneficial to the patient. The main drawbacks, it need learning curve, exposure to radiation, too much exposure to radiation, and thank you.